Hi, I'm Raj Srirajaskanthan, and I'm a gastroenterology consultant at King's College Hospital in London. I've been kindly invited to give a talk today on the spotlight on neuroendocrine tumours of the large and small bowel. And I just thought I'd go through what we'd like to cover during this presentation. So here we'll be discussing quite a large area of the body and basically looking at neuroendocrine tumours that arise from the small bowel and then into the large bowel as well. We'll be looking at how often they occur, and also we'll focus on specific areas where they're more commonly arising from. I'll also touch on some clinical symptoms or syndromes that may be linked to some of these tumours, and briefly overview the treatment as it stands for these type of tumours. So, what do we mean when we talk about the terms small bowel and large bowel? This picture here, which I've highlighted, shows quite nicely kind of the anatomy of the gut. And if we start at the stomach, when we talk about small bowel, we mean moving from the duodenum, which is this area in navy blue, and then going over into the jejunum, which is around kind of 2 to 3 meters long, and then into the ileum. And this is all small bowel. And then the ileum joins on to the large bowel here, which is this pink structure which goes around the bowel. It's called the colon, and then finally reaches the rectum at the bottom. So this is a very large area. The small bowel is often around 4 to 5 meters in length, and the large bowel can often stretch well beyond a meter. So going forwards, in terms of neuroendocrine tumours, we often see that actually the majority of them do arise in the digestive system, okay? And the pie chart on the right shows quite nicely the kind of incidence of these tumours in different areas. And as you can see, most commonly they arise, around 60% arise in the digestive system. And these are commonly in the rectum, small bowel, and duodenum, okay? And what we've seen in the UK, and this is UK data in this bar graph here, is that since 2001 going onwards, there's just been this ongoing gradual increase in the incidence of these tumours. And we're not sure what's driving this. Some of it obviously will be more investigations and earlier diagnosis, but some may be other environmental factors that we haven't yet ascertained. So going forward, I thought it'd be useful just to kind of work our way through the small bowel and large bowel, and we'll just pick up on where you commonly do see neuroendocrine tumours and briefly cover how you would go around investigating them and also moving forward from that treatment. So if we start with the duodenum, which is this first part here, which you can see within this black circle, here, this makes up about 3% of all neuroendocrine tumours, okay? And there are 5 different types that can arise to lead to neuroendocrine tumours. Most of them, around 90%, occur in the first 2 parts of the duodenum. And that's important because it helps when we're determining kind of management approaches, knowing that they're in this area. And what's reassuring is that actually 3/4, or at least, if not more of them, are often small in size, so less than 2 centimeters. What we've seen is that there's actually often possible involvement in local lymph nodes in a significant proportion of these cases, and this is often determined by size as a major factor here. It's important to highlight a lot of the time these are actually picked up by chance when people are having endoscopic procedures done just for other indications. So what do they look like? So this picture here shows kind of this finding we see at a normal endoscopy appearance. So what you have is this little protrusion into the wall of the lining of the duodenum. And this can be quite subtle. So this lesion, even though it looks rather large on the scan, on the picture, is only about 0.5 centimeter in size. And as you can see, it's sitting within the wall of the duodenum. And then the scan you have on the right side just shows uptake in this lesion that we're seeing on the imaging. Now, often with these lesions, when they're small, we can approach them and remove them using endoscopic techniques, which means no need for any major surgery. So here we have a nice endoscopic ultrasound picture showing this small lesion sitting within the duodenum, and we're carefully cutting it out. This can be removed, and you're left with the tumour has been removed and can be sent off for analysis. So in terms of management and treatment of these tumours, it's important that you stage the disease, which means do some investigations just to confirm, even for the small lesions, that there aren't any spread of it beyond the duodenum or elsewhere. And then the management is very dependent on the nature of the lesions. So sometimes for the small ones, you can consider either removing them endoscopically or just observing them. For the larger lesions, we generally recommend, for ones over 1 centimetre in size, definitely having them removed, either endoscopically or surgically. And if they're over 2 centimetres, then generally we recommend a surgical approach if that's appropriate. However, these can be quite complicated surgeries, and so therefore, obviously, a risk-benefit would have to be taken. And importantly, we'd also need lots of investigations prior to surgery just to make sure that that's the right approach to take. If, for example, surgery is not an option, or that there's evidence of disease outside of this area that can't be removed, then there are a number of different medical treatments that can be used, and we'll cover those when we talk about other treatments for small bowel neuroendocrine tumours later on. So once we've moved beyond the duodenum, we then are in the jejunum, which is the light blue or turquoise area, and in the ileum, which is the green area, where there's a nice circle around. The ileum is the most common site for the other small bowel neuroendocrine tumours. However, they can occur anywhere within this region. And often these cases do present a bit later on in the process, with about 50% of people presenting with some metastatic disease at diagnosis, which means that the tumour is spread beyond the primary site in the small bowel and often gone to lymph nodes or commonly the liver. Now, around 40 to 50% of these cases can often produce, the tumours can produce hormones, and these hormones can induce something called Carcinoid syndrome, which is the most common type of hormone-related syndrome. Often, even though the tumours are quite small, around 2 to 3 centimetres in size, they can often have multiple small lesions within the bowel. Okay, and even though the tumours can be very small in terms of the primary tumour, they can lead to much larger metastases. And it may well be that actually it's the metastases or the nodal disease that causes the symptoms that lead to diagnosis, rather than it being the primary tumour. And this leads to one of the issues that we have with neuroendocrine tumours, which is often the symptoms that lead to diagnosis can be quite difficult. Often we've reported that there's been quite a delay in diagnosis by a number of years. And this is because the symptoms can be very non-specific, and commonly people are diagnosed as having irritable bowel syndrome or other types of GI conditions, gastrointestinal conditions like dyspepsia or excess acid. And so as a result, it can take many years for diagnosis to be made. In some people, they present with hormone-specific symptoms, such as carcinoid syndrome, and we'll discuss that on the next slide. And I'd say increasingly, we're finding these as incidental findings. Nowadays, people are using CT scan for investigations for a lot more conditions, and commonly people having scans done for, say, prostate problems or other bowel or kidney issues may end up having a CT scan performed, and this will often pick up an incidental neuroendocrine tumour in the bowel. In some cases, people present due to the mass effect of the tumour, and by that I mean that it's spread, say, to the liver, and it starts causing pain in the liver or liver capsule, and then that can lead to symptoms. Or there's involvement of the tumour within the bowel, and it's leading to blockages in the bowel, which can then present through that route. So, carcinoid syndrome, like I said, is the most common type of neuroendocrine tumour syndrome that we see. And this commonly occurs in patients with small bowel neuroendocrine tumours which have spread beyond the primary site. The key symptoms that people present with are flushing, diarrhea, and abdominal pain. Other symptoms that sometimes can be ongoing are wheeze, and sometimes some weight loss related to this. And when we say subacute obstruction, that's abdominal pain due to the bowel and bowel effects. Occasionally, patients do present with heart failure due to the fact that the hormone syndromes can reduce damage to heart valves and lead to the heart not working very well, and people then present with evidence of heart failure. The flush of carcinoid syndrome is quite classical, and you can see here in this picture, this gentleman has got quite clear carcinoid syndrome facies in appearance. And in the pie chart, bar graph, you can see the incidence of the different symptoms that people can present with. So how do we diagnose a neuroendocrine tumour of the small bowel? And it's based on 4 parameters, really, 4 different routes of investigation. We have biochemical markers, which are usually blood or urine related tests, radiology, which is mainly formed up of CT and MRI scans, and then nuclear medicine scans as well. And this is in the form of PET scans, usually, or octreotide scans that you may have had. And the gold standard still remains histology, which is tissue, so tissue from the tumour site, because this gives us very important information about the tumour site and grade. So there isn't really time to go through all of this, but in terms of the biomarkers, the ones we're interested in are chromogranin, because that's commonly elevated in bowel-related neuroendocrine tumours. The URI5-HIAA is very useful for patients with carcinoid syndrome, and we can use it to assess response to treatments, and also as a matter of kind of correlation with their clinical symptoms. For certain patients with pancreatic neuroendocrine tumours, for example, we often perform a gut hormone profile, and this just tells us if there are any hormones being produced from within the pancreas that could be causing some of the symptoms. And then frequently, for patients with small bowel tumours who have carcinoid syndrome, we frequently do screening for carcinoid heart disease using something called the NT-proBNP blood test. So CT scans are the most common type of imaging that we use. And in terms of this, we often find that a CT scan with contrast can often identify liver lesions like you see in this picture here. And this is helpful at the outset for kind of staging disease. MRI scans are very helpful as well for looking at liver lesions, and actually can be very useful if considering any surgical intervention. So this is just an example of a case whereby someone has a very small tumour in the small bowel, which is just seen by a little fleck of calcification. And then when you do the functional imaging with the PET scans, as I mentioned earlier, you can see the primary tumour light up and nodal disease, which is seen best on the image on the right. In terms of management, so this is very much based around different lines of therapy, and it's beyond the remit of this talk to kind of go through this in detail, but as an overview, for people with carcinoid syndrome, which is labelled as CS in the algorithm here, we often start them on monthly hormone-related injections, with octreotide or lanreotide. And these will be continued long-term, and often may end up needing to be titrated up in terms of dose. And then this is very good at controlling hormone-related secretion, and actually most patients, around 75 to 95% of patients, report an improvement in these symptoms. In terms of managing the tumour, we often then think about resection or removal of the tumour if we can, and or any metastatic disease. And this will often be offered to patients if appropriate. If people have very small amounts of disease or don't need to necessarily have surgery, then we can often take a watch or wait approach to maintain on injections. And then if things progress over time, then there are other treatment options that we can use. And these are quite varied in approach and are very dependent on the individual patient. And for example, in some cases, we may use something like a peptide receptor therapy, which I think there'll be further talks on during this meeting, or more localized therapies such as SERT or embolization. And there'll be other talks talking about everolimus today as well. If patients aren't producing any hormone, then we take a similar approach of starting on the monthly injections. And again, if things progress, then we can use other lines of treatment, the second and third line treatment. Occasionally, sometimes people may have a higher grade of tumour, and this is what we call the kind of G3 tumours or the neuroendocrine carcinomas. And these are more aggressive in their behaviour. And so often we go up front with chemotherapy as a first line treatment, and then further trial the chemotherapy if there's any progression at a later date. So moving on from small bowel, which ends, as you can see on this picture here, before we hit the colon as such, there's often the appendiceal neuroendocrine tumours. And these are often picked up post people are presenting with appendicitis. So there's lots of data on appendiceal neuroendocrine tumours because they are actually very frequent. And around 3 to 5 people per 1,000 undergoing an appendicectomy will actually have a neuroendocrine tumour picked up. Often, in most cases, these are very small tumours which won't need any further treatment. However, occasionally, further investigations and treatment might be required. Generally, for people with small lesions under a centimetre, usually their appendicectomy is curative and no long-term follow-up which will be needed. Often, if the lesions are larger, so over 2 centimetres in size, then we may need to do further tests, plus or minus offer some further surgery in certain cases. And this is one of the benefits of being seen in a specialist centres, that these decisions can be made. Moving forward into the colon, so colonic tumours, again, often present quite late, and that's because the colon is quite wide and expansive, and so the tumours can grow quite large. They often occur around the 7th decade of life, and in some cases, they can often be very similar in behaviour to colonic adenocarcinomas. What we have seen is that if the tumours arise near the cecum or the ileal region of the bowel, then often they're low-grade tumours. However, if they arise further around the colon, for example, in the transverse colon, which is kind of the middle part, then they can be slightly high-grade tumours. Around 40% of patients with colonic neuroendocrine tumours do present with metastatic disease. And again, treatment is very much similar to that we described with the small bowel neuroendocrine tumours. Finally, we're moving on towards the rectum. So this is just above the anus. And interestingly, the rectal neuroendocrine tumours actually make up a significant proportion of neuroendocrine tumours in the American data series called the SEER data set. And this graph here shows the increasing incidence of neuroendocrine tumours within over the last 30 years. And what you see is that really from 1985 onwards, there's just been this increasing incidence of these type of tumours. What's quite interesting about them is actually there's quite a clear ethnic variation as well. So certain races, for example, in East Asia and African Caribbean populations, the incidence of rectal neuroendocrine tumours is quite high compared to, say, Caucasian populations. And it's not clear why this is, and I'm sure there's a genetic component to that. And interestingly, if you look at some Asian studies, the rectal neuroendocrine tumours actually make up the majority of the all types of gastrointestinal neuroendocrine tumours that people develop in those countries. So, how do they look like? They're often picked up at endoscopy, and so these are incidental findings when people are having endoscopic tests, usually being done for another indication. And one of the reasons that we think the incidence has been increasing is that actually in the UK, the advent worldwide actually of screening programs to look for colon cancer, so colonic adenocarcinoma, has meant that a lot more people are having colonoscopies performed, and consequently people are being picked up with incidental neuroendocrine tumours, commonly in the rectum. And so these are just images of how they can appear. Sometimes they're very small, little shiny polyps that you see in the bowel, and other times they can be larger, with an almost donut type shape in the central area of depression. Again, with these cases, it's important to perform staging scans to make sure that you identify if there's any evidence of spread outside of the bowel. And this is often done for the lesions which are around a centimetre or so more in size, so that you can be sure that there hasn't been any spread prior to removal. And then in terms of management, again, we'd be looking at endoscopic therapy can be quite effective actually for lesions which are quite small. And the recommendations are that if there's no evidence of any local lymph node involvement, then for small lesions under a centimetre, they can be removed endoscopically. And there are a number of different endoscopic techniques for removal. And even if they're larger, 1 to 2 centimetres, again, an endoscopic resection can be undertaken after a careful workup. Generally, though, for lesions over 2 centimetres in size, we often think that actually there's a high risk of there being involvement of lymph nodes, and so we often recommend a surgical approach to treatment. However, all of these are very patient dependent, and you have to bear in mind impact on quality of life, risk of surgery, and therefore these guidelines are only recommendations rather than and guidance rather than clear definitive plans for every individual patient, and that needs to be borne in mind. So, in summary, the gastrointestinal tract is a common site for neuroendocrine cancers. They can have a wide variable behaviour depending on the site of the primary tumour, as you've seen between the appendiceal tumours and duodenal tumours and the rectal tumours. They all have very different methods of presentation, but also different approaches to management. For the duodenal and rectal neuroendocrine tumours, often if they're small, they can be removed endoscopically once a thorough workup has been undertaken. And for the small bowel neuroendocrine tumours, they need to be often staged properly with CTs and MRI scans, and usually involving also PET imaging or occultite scans. And assessment has to be made to see whether there's any hormone-related production with these to assess for carcinoid syndrome. Treatment, as I've said before, for small bowel ones is quite variable, and it's dependent on the stage of disease, as in how far it has spread, patient factors such as comorbidities or other ailments and other conditions, and related symptoms from the tumour. But there are a number of different treatment options available for patients, and so these need to be borne in mind when meeting with your team to discuss. Thank you very much for listening, and at the Q&A session I'll be happy to take any questions that you may have.